for inviting me. I've had a great day today. I feel kind of like bringing full to Newcastle, as they say, because there's so much great sim going on here already. And we had a tour of a couple labs today, a couple different sim labs. My husband, Vina Carney, is also a simulation person, so we've had a blast. And we had the privilege of watching Jennifer do some simulations with the residents who very kindly let us observe. We appreciate that. And just fabulous work here. So the whole day has been a blast. Thank you for inviting us. So I'm going to talk a little bit about simulation. I'm going to wander off into some other topics too. I don't have any relevant disclosures. I'm a medical director at the Pennsylvania Patient Safety Authority and a senior scientist at Children's Hospital of Philadelphia. I do want to say that the images that I show and the experience that I describe are not only my work, as everybody in simulation knows. It takes not just a team, it takes many teams. And so some of the pictures come from boot camps, which are one-day simulation extravaganzas. Simulation, some of this information is about safety, but there are a lot of different teams of people who have contributed to here. And the things that I'm thinking about, because I think we are all on learning journeys, hopefully for the rest of our lives. Hopefully, you guys will be able to describe applications of simulation to improve individual and team skills, to improve the systems in which we work, and to support organizational results. If the videos work. Could this happen in your OR? So this is student nurse anesthetist and ENT.
Wait. Before we put the treatment, I gotta get the bleeding under control.
Okay.
It's bleeding from right there.
Okay, it looks like the edge of the cartilage there. Okay, I'm gonna take the cautery here and cautery on. Okay,
Oh my God, the
we have an
tube's on
airway
fire. The drapes are on fire too.
Pull your tube now. Give me water.
Water there. The drapes are on fire.
I'm gonna irrigate the wound.
So probably won't happen in your ORs, but could happen in your ORs. It does occasionally happen in ORs, and of all the services that do procedures that for which fires are a potential risk, ENT is way up there on the list. And actually, I think probably the most common procedure that we do that could start a fire is tonsillectomy, because we're cauterizing just millimeters from that intratracheal tube. So who should respond? You should stay away. Where's the fire department going to come? If you call the front desk and say, can you call in a fire alarm for us, the fire department will respond to the front desk, because they know where the call came from. They don't know where the fire is. Where are the gas cutoff valves? Who's responsible for turning them off? Do they know where they are? So a lot of things you can work out in a simulation that you might never need, but if you do need, then you want to be able to respond promptly. So we ran a series of simulations in the special delivery unit at CHOP, and so this patient is a mannequin. And
building, 6th floor. I got fire extinguisher west.
Sounds not very good, but you can hear they're calling an alarm, and these people have all done their mandatory training. After they load this patient on the gurney and they go to the door of the OR, you have to decide, do I turn left? And we've repeated that simulation multiple times with multiple teams, and nobody realized that there's a fire extinguisher right in the room. Because there's so much visual clutter, and they had never used it, they never had to use it, they didn't know it. So by doing a simulation, they were able to identify this resource. So should this happen, they would do it. So to create a simulation, we start off with a goal, a learning goal, a learning objective, a gap, or something we want to investigate. We have to combine both a simulator and a simulation. Put those together in some kind of an experience. If it's a skills training, then the simulation, the scenario itself may be pretty simple. If it's a scenario with a bunch of people responding, then the simulation may be, the construct may be quite complex. it all together at the end with a debriefing, and the debriefing is really a critical part of making the simulation a meaningful learning experience. And of course, the beauty of simulation is we can repeat it as many times as we want, either to practice or if we are simulating a process and we want to change the process, to modify that process. We can repeat the simulation with modifications and finally tune whatever it is that we're looking at. So a lot of people are familiar with simulation to improve the capabilities of individuals, their knowledge, their technical skills, and their non-technical skills. The simulation this afternoon that Jennifer ran was about delivering bad news, a non-technical skill. I think people are also pretty familiar with using simulation to enhance team capabilities. And again, you can think of those as knowledge, technical skills, and non-technical skills. Those with communication, shared mental models, things like that. We can also use the simulation to improve systems, and I'll talk to you a bit more about that as we go through this. I don't know how many of you guys have seen or had your hands on these, so bear with me if you already know about high-tech mannequins and things like that. But they are commercially available. This is an infant, a pediatric otolaryngologist, so perfect. They breathe, they have chest wall motion, they have normal and abnormal breath sounds. They she's got real residents, she's got real nurses with her, she's in a real patient care setting, and her coach or her mentor or her teacher is going to be prompting her that she has to think about some other things at the same time.
While she's getting the airway, do you want to get anything else ready for hyperkalemia? You know he's hyperkalemic. And think about your other treatments.
Mannequins have palpable pulses, some of them have reactive pupils.
Color's yellow.
Actually, you actually charge it, you actually attach it to the patient, you actually discharge it. The vital signs are displayed on a monitor in real time, and they do respond to intervention. The way I started out with these high-tech mannequins, I mean, we've all done things that are essentially simulations probably for our whole career. If you start off with a temporal bone lab, I mean, that I include that in the broad definition of a simulation because you're practicing on some material that's like. So, but for contemporary simulation using high-tech mannequins, the first thing I did found out about these critters was, of course, put a foreign body in the airway. So the way you can set that up on this mannequin, so the mannequin will be laying there, but the person with the computer controls turning on the vital signs on the monitor. And we'll block the left lung ventilation because there's a foreign body there. Mannequin a little bit of strider. And participants notice that the oxygen saturation is going down. And patient some oxygen, and I can log that. The record that the mannequin will keep briefing, and I will reward the participants by the mannequins are not completely but they are representative, and this is what the larynx looks like on that particular mannequin. So you will see some laryngospasm here. You can see the larynx is not anatomically accurate, but you get the idea, and you understand what's happening. There are low-tech simulators. We use non-electronic dummies. Some of you may remember or may have done this where you put 3 nails in a board and try to suture the tubing together, and the wider the tubing displayed, the more tension, so you have to suturing more and more precisely. This is a simulation device strapped to the arm of a real person, so he can talk to you while you're doing his infusion. And I was really impressed. I have a daughter who has finished medical school, but her first week of medical school, she got to suture a banana. Particularly low cost because they cut the banana in half. This is a low technology simulator. The plastic arm, but it has a test window.
All right.
Red flag.
Small stick.
So this is low tech, but a very sophisticated little simulation for a microvascular anastomosis. And if he's successful, we can put a little blood in the end and see if there's anastomosis leaks or not. We make simulators out of jello sometimes. This is a peritonsillar abscess representation. And this is for novice residents who are still learning like how to use a headlight to look where you want it to look. So yes, Sonia will today, and she'll put that behind a simulator face mask. And so it's not easy for novice residents. This is one of my favorites. This is, again, non-electronic. This is obviously epistaxis. He's got some blood through this tubing that goes in the back of his head and comes out his nose, and she has to coordinate the headlight as well as put the packing in his nose. Use biologic tissue. This is a pig larynx that you can get from the butcher, maybe not the grocery store, but from the butcher. And this is the traditional pig split. Many of you guys may have done this using the cook's handbook with rotation flaps and Z-plasties and things like that. We do use live animals sometimes under anesthesia. We do use cadavers. I think they all fit in the category of simulators. There are virtual reality simulators. This is an investigational one with Greg Wyatt. I had the pleasure to see Nick's simulator today with the 3D image too. That's way cool. You have to drill on it a little bit. This is a commercially available bronchoscopy simulator. And he's going to look into the airway, and he can drop some lidocaine in, etc. Same simulator here, you either put a face on it if you're doing airway endoscopy, you put a different face on it for EGD, and the same device, you just put buttocks on it for the colonoscopy. There are robotic simulators, you have them here, and she is doing a non-anatomic task with just dropping blocks on pegs or something like that. You can see the image up here of what she's doing. And I'm sure this is just the tip of the iceberg, but I found a few of these things. And we, Dr. Montfred actually brought one of these guys, the middle ear simulator, to our SimFest in Philadelphia a couple times. And these are some representations of Nick's work, and then this is Jennifer's very clever carotid artery pulsing. Featured in the 2015 CISL accomplishments. And we do use humans as simulators. This is representing, this person is a Confederate, and she is representing a patient who has some sort of a psychiatric issue and is out of control. And so these people have to learn, this is a combination of clinicians, but security officers, they have to learn how to restrain her without hurting her and without getting hurt themselves. And then the debriefing, of course, is really where the learning comes in. This is a debriefing taking place in the perioperative care unit. Here is one simulation that we ran that has a video component. So argue with that kind of documentation. So some simulation applications going back to skills for individuals, intubation. One of the nice things about having multiple simulators is that people practice on multiple variations of something. They get more fluid, but also they learn to understand what are the commonalities between. So if I have an airway, what are the commonalities of things that I'm going to find there, as well as the differences. This is a simulation for central line dressing change, and this was done as a just-in-time, just-in-place model. So this cart moves. This was for the nurses. We discovered, and it's not unique to CHOP, that for CLABSI infections, the central line associated bloodstream infections, it's actually more likely that they are associated with something that occurs during line maintenance than with the actual insertion. If you look at the timeline of when infections happen. So she's making sure that all the nurses are changing the dressings properly. She just rolls the cart up to outside the door of the patient, and the nurse can step out for 5 minutes and demonstrate that she knows or he knows how to do the dressing change. And she can both obtain information about how many prompts that person requires for her study protocol, but also have him or her repeat the process until no prompts are needed and the procedure is done perfectly. So that's the trained excellence piece of this. And as with many educational interventions, this was associated with a decrease in the central line associated with the infection rate. Causality is sometimes hard to, was temporally associated. These are other simulations that we do at the Anesthesia Fellows Boot Camp. He's learning how to put in a central line with ultrasound guidance. So the machine is here. And he's going to put in a chest tube, and this man can just have such a lovely pop when you go through the curve. Moving on to teams. Technical skills include coordinating roles in resuscitation, but there are also non-technical skills that teams need. They need to communicate, they need to collaborate, they need a shared mental model. It needs to be clear who is the leader and how to channel information, how to bring up maybe contradictory opinions in a manner that's constructive and effective. A simulation of a trauma. This mannequin has a gunshot wound to the left shoulder, not very common in pediatric hospitals, but sometimes shows up. And the trauma fellow is learning to manage medical problems of the patient, but he's also learning how to manage the team.
Yeah, let's roll them real quick, guys, and see what we have in terms of roles.
This C-spine is not yet mobilized other than me holding it.
Sometimes the question comes up about whether simulation makes a difference, and I won't read these all to you, but there is a growing body of evidence that it is effective, that it supports early acquisition of complex skills, it improves procedural skills, it improves surgeon or operator confidence, it improves patient care practices, and has been shown to improve real patient outcomes. And there may also be collateral benefits, such as transfer of skills and knowledge to other trainees, really like to see is some of the processes that occur in simulation, particularly the constructive debriefing. To have that applied to real patient care is actually one of the holy grails of simulation, so that some of the lessons in the simulation are not just how do you do something, but how do you create an environment that fosters learning, and how do you encourage people to be learners. There is documentation that skills relevant to otolaryngology are transferable from simulation to procedures on actual patients. And residents trained on the endoscopic sinus surgery simulator, when compared to controls, had decreased completion time, increased confidence, and fewer technical errors on basic surgical tasks done on real patients. So the transfer of what they learned in simulation was demonstrable in real patients. We're talking now about systems, processes, equipment, environment, information, technology, staffing. These are all systems that we work within. And we've heard the expression, a team of experts versus an expert team. Even if the team is expert, they can't always accomplish a task. I went to this restaurant, and the employees were very nice, and I'm sure they're well trained, and I'm sure they were motivated. But I was not confident that they were washing their hands correctly. So, doesn't matter how well trained they are, and it doesn't matter what the policy is, there's no soap, can't wash their hands. And I think can't wash their hands well. So I think that's true for us. We deliver healthcare in a socio-technical system, and patient characteristics are one piece of what we deal with. We have capabilities of individuals and of teams. We have processes and protocols. We have institutional context and external pressures, financial pressures, equipment supplies, tools, organizational leadership factors, outcomes, work environments, task factors, technology, lots of technology. These things all relate to each other in multiple ways. And I didn't even draw all the lines, but you get the idea, because every one of these things impacts on all the other things. So it's very hard to understand the whole system when it's a socio-technical system, but simulation can help us when there is a problem, and we do a root cause analysis, which is a reactive response to a problem. We can use simulation to try to figure out what happened. And this is a de-identified example when there was a medication error and the wrong dose of a drug reached the patient. That was the real circumstance, but they used, in addition to the debriefing and the focus groups and the interviews and all the things that go into root cause analysis, they had people actually set up the infusion pump and prime it and put the dose in as if they were going to instill it. So they did a simulation. And they found that it's true that the dose double-check protocol was not well understood. Not everybody was doing it correctly. They also found out that the infusion pump stuttered, and if you push the digit 2, you got 22. And that would not have been discovered if they hadn't simulated that incident. If they had just talked to people, nobody would do that. So we can use simulation to refine the processes that we provide care within. Before they put the computers in patient care rooms, they put in computers in a simulation, and they found out that it interfered with caregiver traffic patterns, and so they changed the locations of the computers just based on the simulations. We bought a new brand of infusion pump, and we're going to have to pull out old ones and put in a new one, some of which were in active use. So as you pull out the old pump, it's considered dirty. And despite meticulous planning, it's a very complicated process. And when they actually simulated it, they were able to refine the protocol to do it more effectively. We use simulation frequently before new units are opened or renovated. I see you have lots of new buildings here, so you have plenty of opportunity. But even a simple thing like admitting a patient to the new NICU turned out the rooms were numbered in a manner that the people bringing the patient in, the caregivers bring the patient in, couldn't find the room number they were looking for. And you'd think this would be obvious, but for whatever reason, whoever had the mental construct of the room numbers, it was idiosyncratic. So they actually they changed the numbering on the rooms. And there were other things. They found that you could not keep a hand on the patient and reach the emergency call button with one arm's width, so it had to be fixed. And other things, but that was done by just a simple simulation of let's admit this patient. Before we opened the proton therapy unit, we did simulations. It sort of escalated. We started with a local equipment failure, and then we escalated to a medical crisis, and then we called out the local response team, and then we did full-scale, medical crisis. And we clarified the transport processes. clarified the medication management at CHOP. There's an anesthesia tech, and he can hand drugs to the anesthesiologist. But in this building, there's also a pharmacist who comes. He or she has a bag of drugs. So then where do drugs come from? So obviously something that could cause confusion, but working those details out before real patients were treated was advantageous. In a pediatric hospital, we can just call code, but this was a pediatric patient in an adult hospital, so we had to call it pediatric code. They seem obvious, but wasn't the point of this. Transitions in care are well known to be sort of precarious parts of patient care. And so simulating transfers, this one is transport from the helipad to the
You're gonna notice she has her gloves on.
get from the helipad to the emergency department. Is your oxygen tank full? Does your prox card open all the doors? You know, whatever the issues might be, much better to work them out with a simulator ahead of time. And we have a delivery unit at CHOP which only delivers complicated babies. And so they don't deliver a lot of patients, but they still have mothers at risk of postpartum hemorrhage, so we run postpartum hemorrhage simulations. And the nurses have to go to one place to get one medication and someplace else to get something else, and another place to get equipment, and someplace else to get fluids or whatever, and they realized this was terribly inefficient in an emergency, so they created a cart, and they put the stuff that they needed in the cart. And over a series of simulations, they put more stuff in the cart, took stuff out of the cart, but refined it in an iterative process, but in a real setting where they could really tell like how long it takes to go get things. So I'd like to take on a brief journey through some other concepts that help me kind of understand the healthcare delivery system I work within. And I'm going to talk briefly about complex adaptive systems, resilience, safety monitoring, threats, and I think that humans are certainly sometimes the source of error, but I think they're also the source of solutions. The healthcare systems that we work in, whether it's the microcosm of the clinic or this one OR or the department or the whole organization, is complex adaptive system. And complexity is a feature of the system as a whole, not necessarily each component. So it can be a lot of understandable components, but they aggregate into a complex whole. And the agents within these networks, they act and they react to others. So whatever one hand does impacts on the other hands there. Systems are influenced by the environment in which they operate, and in turn they influence the environment. So it's bidirectional. This environment is not in equilibrium. It's evolving, it's fluid, it's dynamic. Interactions are non-linear, and if you've ever tried to mandate that we're going to do something this way from now on, you know that control is dispersed and decentralized. So I had the privilege of visiting India a few years ago, and please note the very creative winery. Very impressive. And what they're doing is using available resources to solve current problems, which not so different from what we do in our high resource setting. The systems in which we deliver healthcare are not inherently safe. There are contradictions between goals, and people have to try to accomplish multiple goals simultaneously. They have to prioritize and reprioritize, and they have to create the safety. So let's see if this works. We get inundated with the things that we have to make sure. We want care to be safe, we want it to have quality, we want it to have value, we want it to be reliable, we want it to be standardized, we want patient-centered, efficient, equitable, effective, timely, safe. And there's just no end to these things, and they're all good things, and that we want all of these things, but sometimes there are trade-offs, and but in some ways these are also different facets of the same gem. I mean, the thing that we really want is the best patient care, no matter which of these lenses we use to look at that. So I would submit that resilience is a quality that is actually an admirable quality that may help us with these things. Resilience refers to probably organizations as well as individuals which have the ability to recognize and adapt to handle unanticipated perturbations, which require a shift of processes, strategies, and coordination. So you got up this morning and you thought, I'm going to go to the OR and I'm going to do this and this and this, but something happens. You get the patient to the OR or whatever. The picture in the background there, by the way, is that recent Amtrak crash in Philadelphia. I don't know if news of that much started over here, but it was quite an event locally, and there were about 200 patients who came off of that train who went to the local hospital. And you can imagine what that must have done to the hospital intake systems. But there were some deaths on the train, but by and large, the people got handled well. The local people responded incredibly well. The hospitals were resilient in how they were able to take care of a couple hundred patients. So resilience is an emergent property, and there are a lot of different ways to describe it, but I like this because it's relatively simple. Resilience includes monitoring, knowing what to look for, learning, knowing what has happened, responding, knowing what to do and being capable of doing it, and anticipating, knowing what to expect. And these things all interact with each other, of course. So knowing what to look for, these guys, of course, had to figure out that there's a fire with all the smoke, but it may sound obvious, but at the bronchoscopy course, the foreign body course that we run, we have novice residents, and we're trying to drive a bronchoscope into the trachea of a mannequin to pull out a foreign body. And they're focused on that task. And if somebody leaves a light cable on the drape, we activate a fog machine, and the whole room fills with fog. And these individuals the learners are still so focused on how to manipulate the instruments, they were completely oblivious to the fog filling the room. So you need enough bandwidth to be able to monitor not just what you're doing, but what's going on in the room around you. I kind of think of ORs as 12-ring circuses. Responding, knowing what to do and being capable of doing it. So he's practicing, so he'll know what to do the next time it happens. Learning, this is an example of a mannequin that we use with either, and some years he's had thyroid surgery, and other years he's had anterior cervical ACG, anterior cervical discectomy and fusion. But in any event, he has a rapidly expanding neck hematoma, and you can see that when the hematoma is open, it does spurt blood quite nicely. And so we have to figure out what has happened and learn from that so that we can treat the next patient who might come in. And we can use simulation to help develop skills of anticipation, finding out, knowing what to expect. This is a published photo. These are two conjoined twins with tissue expanders being prepared for their separation. These are the dolls that one of the nurses sewed together so that the team could practice. You see the color-coded tubing, so the team can practice how they're going to, once they separate the children, how they're going to set things up so that the separation can proceed in a manner that once they are separated, they can separate the kids without entangling all the cords and lines that are always present in the brain. So simulation is very adaptable, and we can replicate almost any part of a process or a system. This is our patient who develops a problem, obtains a consult, has surgery, recovers, and lives happily ever after. And we can simulate the surgery or aspects of the surgery. We can simulate the process of going from the consult to showing up on the day of surgery properly prepared. We can simulate the transition or the handoff from surgery to the recovery room, or we can simulate the whole thing, but the magic of simulation, of course, is that start and stop anywhere, and multiply as often as you can. So, using simulation, we can provide opportunities for directed learning, improved teamwork, and improved environment. And with those things, I think we can decrease cognitive load, improve the adaptive capacity of ourselves and our systems, and increase our margin of maneuver so that our actions remain safe. I'd like to talk to you a bit about work as imagined versus work as done. The famous philosopher Yogi Berra says, in theory, there's no difference between theory and practice. Yes, there is. Even if the world were perfect, it wouldn't be. So what we want to improve is work as done. And I think you can do a lot of really fabulous things in simulation centers. I think that's essential. I think you can also do some very important things with insight to simulation. We have work as imagined, and that's when people get together and talk about how things are done, and it may be a focus group, it may be a survey, it may be an exercise of putting stickies on the wall. I mean, they're all manner of trying to understand work as imagined. And that's important and it's necessary, and sometimes things are simplified when you do that, and that may be necessary to get the mental construct. It may also be very complicated. So I believe this is necessary. I just don't think it's sufficient. There's also work as abstracted. You know, with huge databases now, we can cull the data from thousands of episodes of care and say, well, you know, this drug really does work better than that drug under these conditions or whatever. Or we can say, yes, do we need to add an ultrasound machine, or do we need to add a nurse, or do we need another exam room? You know, what do we need to improve the flow through our clinic? So that's work as abstracted. Again, very important, very powerful. Doesn't always tell you how or why. And I think the value of insight to simulation, when you're working with real teams, real equipment, in real locations, I think that gets you closer to understanding and thereby improving work that's done. There are hazards to doing insight to simulation. We always worry that some of our equipment or supplies will get out in the wild. I like this adaptation from the Children's Hospitals Clinics of Minnesota Children's Simulation Center. It's pretty obvious this is not real IV fluid. Likewise, their meds are all colored. I think that's a good visual, you know, sort of barrier. And this is what they do at CHOP. So they have labels on everything, which is a good idea. I work with Pennsylvania Patient Safety Authority, and in Pennsylvania, there is mandatory reporting of serious events, incidents, hazards for the state of Pennsylvania for hospitals, abortion facilities, ambulatory surgery facilities, and birthing centers. And there's also the long-term care facilities report infections. But anyhow, reporting is based on harm or potential for harm, so it doesn't require an error to be reported. And it doesn't have to affect an individual patient. It can be a hazard and still be reported. Reports are confidential and not discoverable, and should not include patient or provider names. We don't want to know who. We do want to know the facility and the location, but not the patient. So I looked through the database for a 10-year block for terms sim, mock, practice, reverse, and read the narratives, and excluded things where simulation was used to describe the radiologic simulation before radiation therapy, or Similac. Practice meant, you know, like family practice, where this is our standard practice, and there were actually a few also where mock was somebody mocking, somebody disrespectful. So I pulled all those out. The database has 2.5 million reports, and in that 10-year time period, and about 2,000 that had some variation of these words in them. And of those 2,000, there were really ended up with only 16 reports from that 2.5 million that had anything to do with simulation as we think of it. And I looked at whether the simulation may have attributed to the event, and these are de-identified examples, but for instance, maybe somebody was learning how to use an epinephrine auto-injector and then used that practice device on a random person. That's not a real example, but you get the idea. Or there could have been simulation which was implemented in response to an event, and that typically was investigating device malfunction. There were reports where simulations was serendipitously identified in an event. So for an insight to mock survey, this is de-identified, but a real imminent patient hazard was identified, so it was just serendipitous. It just goes that survey people were in the room. And then there was one event where the equipment wasn't available, but I couldn't tell if that equipment wasn't available for real patient care because it was being used for simulation or because it was being used for clinical care. So I ended up with 15 analyzable reports. But we also collect the reports. The submitting facility attaches a harm score. So 3 of these were submitted as A's or B2, so unsafe condition or event did not reach the patient because a person intervened. 9 of these were event did not cause harm, did not require additional monitoring, and 3 events required monitoring to confirm that there was no harm. Either required some sort of intervention to prevent harm, but there were no events involving simulation that had either anything in range from temporary harm. So there is a debate about the safety of in situ simulation, but I think there's potential for huge benefit from in situ simulation, and at least from this very limited and analysis. It's not showing up in our reports. I should say the analysis was thorough. So safety 1 and safety 2. Safety 1 is about what goes wrong. You all are probably very familiar with safety 1. This thing happened, we're going to find out what it is, we're never going to want it to happen again. Important, not sufficient. What goes wrong, defined by failure, and safety 1 is achieved by limits and constraints. This thing went wrong, we're going to set up a policy so this can never happen again. This thing went wrong, we're going to set up a hard stop so they can never order that drug in that way again. That's safety 1. Typically, the inquiry about safety 1 is critical. What things were done that were not good. But if you think about it, these events, it's important to understand them. There's really a very small number, and there's a lot we can learn by looking at what goes right. And safety 2 is what goes right. So what goes right is defined by success. It's when in the debriefing, in addition to things that I wish I could have done better, and also, but you know what? You gave me the information that I needed to successfully accomplish the procedure, or it was very helpful when you reminded me that the dose of the drug is whatever it is, but reinforcing the things that go Safety 2 is achieved by adaptability, and the inquiry for safety 2 is appreciative and positive. So we are faced constantly with threats to our patients. And a regular threat is something that we can anticipate. In this case, she's figuring that sooner or later one of her patients may have cardiac arrest and she might have to perform CPR. We do that. I mean, we get trained in BLS or ACLS or PALS or whatever because we don't know when it's going to happen, but we know that it's likely to happen. And an example for us is post-tonsillectomy hemorrhage. I mean, it's not common, but it's going to happen. Somebody's going to show up in the ED with post-tonsillectomy hemorrhage. Situation 2 is an irregular threat. It's unexpected but not impossible. Requires self-organization and improvisation, so you can't necessarily respond to this using the rules that you already have in place. You may have to do something Simulation is very good to prepare for situation one. I think simulation can also be helpful to prepare, maybe not as proactively, but certainly at least reactively to this irregular threat. And is a perfect example. A lot of organizations use simulation. In fact, your organization uses simulation to prepare for potentially for an Ebola patient. We saw that today. But sometimes people do a very good job in isolation when it's donning and doffing the equipment that seems to be the issue, but they don't necessarily put that together well in the real space. So practicing in the real space is a valuable piece of the preparations. In situation 3, unexampled events are so awesome and unexpected that we can't even anticipate them. So I can't tell you what the next situation 3 event will be. Nobody knows. But healthcare workers will be there. Rules to riding a horse. The horse won't necessarily know. Absence of resilience is brittleness. And this is a lack of buffering capacity, so inability to absorb or adapt. And the stiffness, people can't restructure in response to changes or pressures. So when those 200 patients arrived in the emergency facilities in Philadelphia, they probably restructured. And they may have changed their priorities a bit. They may have decided that they're going to take care of all the patients now, and maybe the documentation could wait a little bit. So they may have degraded their processes a little bit to accommodate. But that's better than cultures. Brittleness gives you lack of margin, so your performance boundary of what's safe may cross that boundary. And that boundary is not always visible. If you're brittle, you collapse, meaning the system just falls apart as opposed to degrading gracefully. When you start reprioritizing and stuff that's less important gets pushed off for later. Many structures in our professional lives and in our society are rigid and brittle, and accidents waiting to happen. And our desperate attempts at fixing them, such as by making more and more rules so that things are more and more rigid, may have a negative return on investment. And I'm not saying that rules and standards are good. I'm just saying you have to be thoughtful in how they're crafted and how they're applied. We also tend to deconstruct things. Something bad happened, we're going to look for the root cause, and the root cause of that root cause, and that root cause, and we're going to get to smaller and smaller pieces and fix those pieces. And it is important that all of those pieces work correctly. But if you take all the pieces, no matter how well you understand all the pieces of this car, that still may not tell you how the car functions when you put it all together. So you still need to have an understanding of the whole. And then the other analogy I take out of this picture is that you may find the best carburetor from BMW and cars, the best engine from Ford, and the best muffler from who knows. It doesn't mean you can put them all together. So we have to think of that when we think of evidence-based practices, that there's something to be learned from that, but we still have to understand how that fits within our complex system. Finally, a few words about humans. You've heard this: to err is human, and to reinforce that, to err is human, don't forget. So it's true to make errors. But, I'd rather think of it this way. People working in healthcare are among the most educated and dedicated workforce in any industry. The problem is the system needs to be made safer, and we need a system approach to make healthcare safer for our patients. If the healthcare delivery was created by humans, maybe not intentionally. I mean, all the ramifications may not be intentional, but there are humans in every part of the healthcare delivery system. So if we look for a human in the path of failure, we're going to find one. And even if we have our just culture and no blame culture for the sharp end providers, people like the coal face, if we are pushing that back further up the administration of the organization will still find the human. So the assumption that humans have caused this problem always. I like this better. It's not bad people, it's bad systems. I love this tagline from MedStar: to better is human. To blame is human, to fix is to engineer. So humans, we can't live with them, can't live without them. I think that in providing the best care for our patients, humans are indeed a source of error, but they are also an essential and awesome source of